This episode of the Barry Chronicles is proudly brought to you by Bariatric Support Australia.
Hi, so we're here with the amazing Dr. Terri-Lynn. Again, we're so glad that you could join us again on the Barry Chronicles. So thank you.
Yes, thank you.
Absolutely, my pleasure to be here. Thank you for inviting me.
That's great. So today I was wondering if we could discuss something that does come up a fair bit is pregnancy after bariatric surgery. We see it so often and people are shocked. Some people, it really is an emotional thing, especially for people that haven't been able to conceive pre-surgery and suddenly they're just like, oh my gosh, what's going on?
Yes.
So can you shed some light, I guess, on why it happens?
Well,
we know why.
I don't know why, Damo.
That's in the bees talk.
Yeah.
Look, I completely understand where people, women in particular, are coming from. May have been, told that they have subfertility for whatever the reason. They may have been given a diagnosis of polycystic ovarian syndrome, but we do know that any insulin resistance, polycystic ovarian syndrome, and weight loss can significantly increase patients' fertility and particularly talking about women's fertility. And we can even see that increase in fertility before a return of regular periods as well. And this, again, can really take some people, by surprise. Certainly in the post-bariatric surgical patients that I see, I always make sure I talk about birth control and contraception. And I do dance around the question a little bit because sometimes I'm even asking women who may be in the perimenopause and, I say to them, sure, you might be reaching the average age of menopause, but it's a low probability, but it's not impossible, and there is this term called menopause babies. But I do believe, if I'm remembering the statistics correct, that the average female age for bariatric surgery is more in the mid 30s to lower 40s. Gosh, trying to get my numbers out. And so this is, a highly fertile time period. And so absolutely, I always talk about birth control when I see the patients post-surgery, but this conversation actually does need to happen pre-surgery as well. And in particular, to understand that even if a patient is taking contraception, particularly if they're taking some sort of oral contraception, the effectiveness of this post-bariatric surgery is expected to be significantly reduced. And certainly some of the international guidelines about birth control post-bariatric surgery is for what we call these non-oral long-acting reversible contraceptions for that reason. And there's another reason that we recommend long-acting, which I'll get to in a moment. But I'm just giving you guys time to reply to my big spiel that I just did then.
No, that was awesome. And actually, now this requires me to cast my mind back quite a way. But when I had my lap band, I actually fell pregnant. The drop in weight wasn't huge for me. It was about 20 kilos that I lost in total back then, as opposed to 100 kilos when I had my gastric bypass. But I was diagnosed with polycystic ovarian syndrome, and I was not expecting at all to fall pregnant, and I did with a lap band, which was not fun. Lots of reflux, lots of all of that kind of thing. So can you talk, because you said about, and am I right to assume that our oral contraceptive methods may not absorb in the same manner after bariatrics?
Yeah, that's exactly right. And it depends on the type of surgery. But I would be suggesting that any form of oral contraceptive is not reliable in the post-bariatric patient,
Okay.
particularly in that first 12 months. So we know that there is significant changes in all drug, what we call pharmacokinetics and pharmacokinetics. That is how they are activated and how they may be absorbed. So it's very different. But we also do know that the body does adapt. And so although I'm saying that we should assume oral contraceptive is not as effective, it might be completely different, 2 or 5 or 10 years down the track. But certainly in that very early, 12 to 18 months post-bariatric surgery, we need to be very aware that a lot of medications may not be absorbed and therefore may not have the same sort of effect that we would have thought pre-surgery.
Wow.
And there's not a lot of research about individual medications as well, and how they change post-bariatric surgery. And again, it's different for different surgeries, but it's certainly something that the all prescribing doctors should be aware of. But it's hard to actually know that information unless you have a specific interest and know where to find that research.
Mm. Mm.
And there are some sorry, we're getting a bit off topic with regards to pregnancy, but there are some medications that have what we'd call a smaller window with regards to the difference between side effects. So there are some, and effectiveness. So certainly there are some medications where doctors need to be proactive in looking at the serum levels or looking at the side effects or the therapeutic effects and adjusting medications according to how a patient responds. And so in particular, I'm thinking about some of the mental health medications, the oral contraceptives, those sorts of things where they're long-term medications. We certainly know that people's replacement thyroid medication significantly drops. I think that's one that both patients and doctors are a little bit more aware of, but some of the others we need to be mindful of as well.
That's why it's so important to have that great team around us, isn't it, after bariatrics?
Absolutely. And look, the person that I call on if I don't have access to the research in front of me is a clinical pharmacist. And a clinical pharmacist who's at one of the public hospitals in Brisbane where I work, who's part of that bariatric surgical team. Yeah.
Wow. Yeah, that's actually, see, the thought of how medications absorb. I mean, I do know from a few friends that take different medications, for all different issues that have had bariatric surgery. I do know that some of them have seen a significant increase in symptoms because obviously they're not absorbing their medication in the same manner that they were. And obviously that's why sometimes we can find ourselves pregnant.
Yes, absolutely. That's exactly right. Yes. And so getting back to topic, the reason why the international guidelines are for these long-acting reversible contraception is not only because what we're talking about when we say that is it might be the rod in the arm, which is known as the implanon. It might be a IUD, which stands for intrauterine device. The most common one that people would know as an IUD would be the Mirena, which is a very, very low dose progestogen only IUD that sits in the uterus. But there are some non-hormone IUDs, including the copper IUD. And then the third long-acting reversible contraception is the needle, which needs to be given every 3 months, and that's called Depo-Provera. Now, there's pros and cons in all of those long-acting reversible contraceptions, but the reason that the longer acting is recommended is to align with the advice of to try and avoid pregnancy for a minimum of 12 to 18 months post-bariatric surgery. And the reason for that is in regards to the nutritional status of both the mother and nutritional risk for the fetus if pregnancy were to occur within that time frame.
Yep. Dame, would you like to, just with the microphone issue, do you want to?
Yeah, we're just trying to fix something. So
we're just finding you a little hard to hear.
Oh, okay. Is it because of background noise? Because I can move.
No.
That's
actually a little bit better. I'm wondering if it might be a microphone positioning.
Yep. Is
issue,
that better?
maybe? Yeah, that's actually good. You're right?
Yeah. Just my computer's getting old like me.
No, that's fine.
Yeah.
Yep,
So
great.
I think one of the things that it really becomes such an emotional topic, doesn't it? You know, because gee.
Yeah. Well, a lot of people do, as you would know, they go down the path of bariatric surgery in order to be able to conceive. And
then one of the things that we see a lot is, you know, how is it going to affect my weight loss? And, you know, is it, you know, if someone suddenly finds themselves, you know, a couple of months after surgery, they're pregnant, and, you know, it's a legitimate worry, isn't it?
It is, absolutely. And I feel that, you know, there's often the time pressure, like you said, Tash, is, you know, if a lady is looking at bariatric surgery and one of her, you know, biggest motivations is to improve her fertility for pregnancy, you know, there's, you know, the lead up time for making the decision of surgery and being able to know how to finance that. So that all takes time. Then, you know, the recovery from the surgery, and then, you know, someone's telling them that they can't get pregnant for 18 months, you know, and I know that depending on that individual's age, you know, there is this pressure of you know, having babies before a certain age because of egg quality, and also the older a pregnant lady is, the more theoretical increase in complications as well. So I definitely see that there's that time pressure, and I do think it does behove the surgeon who's having the conversation with the patient to really, you know, make sure they are aware of these expectations, so the decision making is with, you know, eyes wide open about some of these expectations.
I totally agree. I remember when I fell pregnant with our last child, geriatric mother.
That's an awful word, isn't it?
was written all over all of my testing things, and I was like, oh my God. Okay.
Okay.
Wow. Rude, but okay.
That you've lived to be this age. It's amazing.
I think I had something similar, and I think the line in the sand was 35, but I think they've increased that recently as to what, you know.
I'm glad to hear that. I really am, because it was. I just found it quite a confronting sort of a thing to have written in all of my paperwork and everything like that.
Oh, absolutely. And let's think about, you know, how much stigmatizing language, you know, medical professionals use.
Yes.
Know?
Yeah.
And when I was told I was morbidly obese.
Yes. Yes, absolutely. Yes.
Yeah.
Terrible. How does the I mean, we all know that nutrition is such an important part of our weight loss journey, but also in pregnancy. And, you know, I remember buying bags of oranges for my wife when she was pregnant because, you know, she was just like, I need oranges. So it's like, okay, must be a vitamin C thing. But when we're so limited in what we can actually consume, where do we even begin with? Well, I don't have to begin anywhere with it, but where would someone begin with that?
So again, that's part of the reason why the international guidelines is to try and avoid pregnancy until that 12 to 18 months. So people who have experienced bariatric surgery will know that there's a huge difference between what they can tolerate, how much food that they can consume at once, and also over the end of a day at that 12 to 18 months, as opposed to the first three months. So being further down that recovery journey does mean that there is increased chance to get as much quality nutrition as possible through food, but there will be very specific multivitamin and mineral needs and replacements once a person post-bariatric surgery becomes pregnant as well. And can I say that it's not necessarily bariatric specific alone, and it's not just antenatal branded specific alone, and a lot of it will be very much what the individual requires and also what type of surgery they have. So it's an extremely nuanced area from a nutrition point of view, and I would recommend anyone who is planning pregnancy post-bariatric surgery or are currently pregnant to make sure you do have a qualified nutritional professional who is experienced in this area, because it really is quite unique and a narrow field of practice, and you need to find that expert.
Where would someone find somebody like that?
I do believe that Dietitians Australia have a website where you can find a dietitian, and I'd be looking specifically for a bariatric qualified dietitian, and within that space, yes, someone who actually did understand prenatal, antenatal care. But that's where people could search that database for sure. Okay. And then of their list, ring up and actually say, do you specifically have under knowledge and skills in the post-bariatric pregnancy space?
Yeah, because if it does happen earlier than what someone's planning, then we have to give ourselves the best chance of maintaining a health.
So because this is another question that is very frequently asked within our community anyway, but what are the potential risks and complications of falling pregnant prior to that 12 to 18 month mark? Of course, we don't just want to have a scary conversation here, but I think it's very important that we do have this conversation and that it's answered by a professional.
Yeah, and look, there isn't a lot of research for me to be very black and white about things, but I can talk to you about the theory in general, and it comes down to the effects on the fetus and developing baby, as well as the effects on the mother. So if I just talk about the developing fetus, it's so important in regards to the what they call the neural tube development. So even before a patient will know that they are pregnant, their fetus is developing, and they're developing the very early organs. And in particular, we know how important folate is for there's something called neural tube defect. And so if when we talk about pre-pregnancy planning, we recommend all women, whether they are post-bariatric or not, to be starting folate supplementation as a minimum prior to what we call trying to conceive. That would be as a minimum. And then again, if I'm wearing that dietitian hat, I'd be saying in addition to that, I'd make sure that there's some iodine, and particularly for most women, some iron as well. And then if they are post-bariatric surgery, there's even more of a concern with regards to folate and iron and vitamin D in particular. So I'd be suggesting that, if someone is hoping to fall pregnant at some stage post-bariatric surgery, to possibly have a greater level of vitamin baseline assessment, and if they are for whatever reason unable to follow the guidelines, whether planned or unplanned, with regards to delaying pregnancy for that 12 to 18 months, then as soon as they find themselves pregnant, or even before, to link in to look at what those extra requirements that they will need. So that's just in regards to the micronutrients, what we call the vitamins and minerals, but also in regards to having enough protein and energy for adequate growth of the baby. So we've gone out of that first trimester, which is all about that very initial, what they call organogenesis, which is developing of the organs. And then we're going more so into that second and third trimester, where it's really about the growth of the baby. So if the baby is unable to get enough of the macronutrients, meaning the protein and the energy in the diet from the mother, then they'll have something called intrauterine growth retardation. So again, big names. As soon as you make it medicalise it, you've got to call it a big name. But basically that is otherwise known as small for gestational age. Again, just having a baby that's not growing particularly well. And the concern is that in doing so, that may actually bring about what they call epigenetic changes in that fetus and that baby, which you may not necessarily see when the baby is delivered or in the first few years of life. You might see that as an adult. And having significant influences from a metabolic health point of view. And I'll give you an example. I think it was one of the European countries, and this was in, I think it was in the 50s or something like this, and they had some sort of famine, and there was a cohort of women who were pregnant through this famine, through no fault of their own, are unable to get enough nutrition, and then they were able to follow up the babies of those mal or undernourished pregnant women, and they saw some of these genetic effects in the offspring later on. So a lot of time you'll hear stories about someone who got pregnant earlier than thought. They did okay in their pregnancy, had a live, healthy baby, but there is a potential ripple effect that you're not necessarily going to see until that baby is growing up.
Wow.
And look, and this is, and again, I don't want to be scary about this.
No.
But I think we, sometimes, and I do very much understand the overwhelming and consuming desire to have a baby, and then the time pressure to do that. But it's not just about the mother's health, it's about the baby's health. And I find that when women are pregnant, they are so motivated to try and do the best they can for their unborn child. And so if I'm trying to convince someone to please delay pregnancy, I'd be saying it's for the health of your future child. Because I do think that, mothers, parents, I should say, do self-sacrifice. That they do that, and I can understand that. But I'd like to turn that conversation on its head and say, by doing this, you're actually setting your child up for better metabolic health.
Wow, that it really is such an important thing to have heard. I've never actually heard myself about the potential effects that could have as a child grows or into adulthood. Of course, I should have thought of that before now, but wow.
Yeah, there's quite been a long-known association that again, small for gestational age babies are actually being a small for gestational baby is a risk factor for developing metabolic health and obesity in later life.
Wow.
Yeah. So
that is definitely something that we should be very, very cognizant of, isn't it? As we're considering pregnancy, or the potential of a pregnancy post-bariatrics, making sure that we are in that really good place within ourselves. Now, as far because you said about the importance of protein, as far as that goes, obviously we all know and believe and understand that protein that we can get from our food is of course the primary way that we should be trying to get our protein. Is it acceptable to use a protein supplement in pregnancy?
I don't think there is any known significant contraindication. So there's no, you definitely can't do this.
Yeah.
And then it's I talk about, levels. So the best level, is nutritious food. But if you're not meeting your needs, absolutely, that's better to do something than nothing. Because again, if you're not getting your protein intake orally, particularly in pregnancy, your body will use its own muscles to supply that protein. And even though we talked about the concerns of malnutrition for the baby when they are an adult, the other thing that we haven't talked about is if you are as a mother who has a baby developing in their uterus, if you are unable to get your minimum needs, then your body will prioritize the baby and trying to get the nutrition to the baby to the detriment of your own body. So, for example, starting to eat away your own muscles to supply enough nutrients to the baby if possible. And also in particular with regards to getting the calcium for the baby's developing bones, and so that women can very much lose their own bone mineral density as a sacrifice for the fetus. And so, it is a two-edged sword of potentially having long-term effects for the baby, but also the mother in regards to bone mineral density and loss of muscle and all of the consequences of that as well.
Wow. So could that also cause dental issues as well then if the, babies... Wow.
Well, yes, I think that in general, the babies come out if they're not getting enough, the mother's not getting enough nutrition, the babies will be small for gestational age, but they often will be okay with regards to the baby's development of bones as well as dentition, but it's to the detriment of the mother.
Yeah.
That seems to be that mother thing.
Start sacrificing your own body straight away.
Yes.
And it never stops, does it?
No, it never does. All the sacrificing, all the things.
Eventually, it just moves to the wallet.
Well, that's exactly what I was thinking. It becomes financial sacrifice.
Yeah, the financial and the peace of mind, perhaps.
Yes, mental health. Yes.
Yes. So if someone is pregnant and they have had bariatric surgery, are there any signs or symptoms that should be taken a bit more seriously because that person is a bariatric person, as opposed to somebody that was just happily going along, pregnant?
Yeah, I think that you kind of need to be proactive as a post-bariatric surgery pregnant lady, because I'm thinking about things like iron deficiency. If someone is iron deficient, you'll be tired, you'll be short of breath, you might have low blood pressure, and if you were to ask 100 pregnant ladies, they'll say, yes, I have all of those things. That's part of being pregnant. But certainly that's why I think that forewarned is forearmed, and trying to get ahead of the curve. And the other issue in regards to post-bariatric surgical pregnant ladies is in regards to how do you screen for gestational diabetes in pregnancy? Because the oral glucose tolerance test is not in general recommended, depending on what type of surgery that you have, and knowing whether there is insulin resistance and concerns from a glucose regulation point of view, again, is really important. More so for the baby in regards to that epigenetic phenomenon than the mother per se. So again, all I can say is for mothers out there, please do this for the future health of your babies.
Wow.
It's I had gestational diabetes with our first child, and was subsequently, of course, tested. And when I had my glucose tolerance test with our last pregnancy, even though I'd had a lap band, I still felt very, very subpar during that test. And this is a commonly debated topic within the bariatric community, on BSA anyway, whether the glucose tolerance test is still needed. Are there other ways to look into the potential of gestational diabetes, or is it really just that the glucose tolerance test is what's needed?
There are definitely other ways, and it's being debated internationally at the moment. A lot of it will depend on the mother patient's pre-pregnancy risk, and so certainly if there had been a previous diagnosis of type 2 diabetes, which might have gone technically into remission post-bariatric surgery, we know that the genetics for insulin resistance are always going to be there, but no, we can be doing things like early into the pregnancy, fasting blood glucoses and what we call HbA1cs, which is that average 3-monthly blood glucose, to get a better idea of where that person's risk might be, and then potentially looking at modified glucose tolerance tests for that post-bariatric patient population. But again, this is being debated with regards to guidelines. And what I have found is that depending on whether you're in private maternity care or public maternity care, things will be quite different. But certainly at one of the big maternity hospitals that is in Brisbane, they don't do the oral glucose tolerance test in post-bariatric pregnant ladies.
That's actually very good to know. I've had a number of people message me and tell me just how horribly sick they were. They were unable to complete the test. Is there other ways? So I'm glad that it's being talked about and discussed, because it really is an issue that is relevant to our bariatric people that are pregnant. And we definitely need to have some sort of a standard so that we know, what should we be asking for. And I think a lot of the time that's also the challenging thing, going into an appointment with a doctor after bariatric surgery. Maybe you've discovered that you've fallen pregnant prior to the guidelines, and then you're instantly feeling, oh my goodness, I've done the wrong thing, and now they're going to think that I'm silly or whatever. And so it just can sort of put people on the back foot.
Absolutely.
I think what's made me feel just so incredibly sad is that there are times when I know of people that have even avoided seeking medical care early on because they were just so overwhelmed by what was happening. So what would your message be to somebody that's in that sort of situation, Dr. Terry?
What I'd like to say is it's not your fault. And I think that it's something that if you act earlier rather than later, then you're doing the best thing you can by for the future of your baby.
Yeah, absolutely.
And this is an area that a lot of healthcare professionals don't know a lot about. Excuse me. So finding that support that you need may be difficult, but to say, this happens frequently. We know that it is, takes people by surprise. It's not your fault, but do act earlier, because it will make a bigger difference acting as soon as you find out, rather than months down the track. And that, yes, you might need to search out healthcare professionals who really understand what's going on, because for example, if I think about, again, I'm just thinking about my local referral public health maternity hospitals, the patient won't get a booking in appointment until they're 20 weeks pregnant. And 20 weeks is, gone beyond what we would call that initial organ development. And their first point of contact might be their GP to get the referral to the antenatal unit. And again, this is not the concern about the unique nutritional concerns in the pregnant post-bariatric surgical patient. It's not something that most GPs would have a really good understanding of.
Wow. So it shows the importance of having that good team around you when you're having the weight loss surgery, isn't it? That
Absolutely.
If this did happen, then you straight on the phone to the team. And
20 weeks is a long way in.
Yes, so I don't know if this is similar to other states, but certainly, yes, in one of the major maternity hospitals in Brisbane, they don't, I send the request form in as soon as my patient is pregnant, and we've confirmed all of those things, but they won't be seen at the hospital clinic until 20 weeks. And so again, as a GP, I'd be talking about doing the first trimester genetic screening and all of those sorts of things as well. And that's where, talking about their vitamin and mineral status as a baseline at that point in time, and making sure they're on the appropriate antenatal vitamin mineral, which is not necessarily just the proprietary one. It might be a bariatric specific, or it might be a combination. It's not an easy ticker box sort of thing. It is individualized.
Yeah, maybe our listeners might like to comment and just let us know, if you're from states outside of Queensland, just let us know what your experience has been within public health, and in terms of being referred on, and how long that process takes. Once you discover that you're pregnant, because 20 weeks, you're already halfway.
That's exactly
there.
right. That's exactly right. Yeah.
Yeah.
And that's why I call to your audience to, yes, be proactive, because I think that there is a lot of unknown about this area, and so I do think that patients might actually have to be, I guess, a little bit pushy, only because of, and I'm saying this in a nice way, but the ignorance of the standard healthcare practitioner who's trying to know a little bit about everything. But this is a very specific, nuanced, not a lot of is known area of health. Yeah,
well, I mean, it would still be for most just general practitioners, it would be a very rare issue to ever come up.
Yeah, that's right.
Yeah, and you certainly don't want to be taking your advice from someone down at your local gym, and it's so important to have the right advice.
Yeah, that's right. And look, people might be advising in regards to general post-bariatric follow-up, but pregnancy is very unique, and it's not just looking at the pregnant mother, it's looking at their unborn child as well.
That's
so
right.
it's very nuanced and
it's, well, for most people that are pregnant post-bariatrics, they're happy and excited, and we just want them to have the best possible experience and a good outcome. And it's just so important that I think that we do learn to advocate for ourselves, and that we do learn to ask those really good questions. So, Dr. Terry, would you be able to tell us some really great questions for our listeners to ask if they find themselves in this, in this sort of position?
Yeah, I think the first thing is to go to your preferred trusted primary healthcare professional. Let them know that you think you're pregnant, have that confirmed, and say, I do understand that because I'm post-bariatric surgery, I'm at increased risk in regards to nutrition, and that I should be having earlier investigations to help me know how to get the best vitamin and mineral supplementation, and it may be more than just a antenatal brand, and also to have those earlier discussions with regards to, well, where can I get that help if I need it, and also in regards to having some of those early discussions about gestational diabetes risk assessment.
Yep, that's excellent. I mean, I know if I was in that position and I just knew what to ask, it would really make me feel very much more at ease. Yeah. So, as far as the glucose monitoring goes, is that something that obviously it is something that a GP is well positioned to be able to do? How often would you suggest that should take place?
It really does depend on the patient's current risk, but certainly for patients who've had a diagnosis of type 2 diabetes, it would be to see where they are in that potential remission post surgery. And so if I take the surgery part out of that situation, I'm doing that fasting blood glucose and HbA1c to make sure the person in front of me doesn't meet the criteria of type 2 diabetes when they are actually early pregnant. Because that's a different diagnosis from gestational diabetes. In general, gestational diabetes, it only becomes a problem after that 24 plus week area gestation, because it's the changes in those pregnancy hormones that brings about that insulin resistance. So really any sort of earlier investigation is because someone may have had a type 2 diabetes diagnosis, and we're trying to see where they are in that potential response / remission to that, which is completely different from something that we would call gestational diabetes, where the hormones have increased that insulin resistance. So it's almost like a two-stage investigation and approach based on the history.
I think that's excellent. That's excellent though, and it's if people had been proactive and asked those questions early on, and they had that monitoring in place, would that then be something that could potentially be used? And I know that you said that there's currently debate about all of this, but instead of a glucose tolerance test down the track?
Yes, potentially.
Yeah. All right. Awesome. So that's a very good tip for our listeners to just be proactive on that from an early stage.
And look, Cash, if I can, when I get up here, I'll just see if there is something that might be a resource that I can send you later that you could have a link to. Great. Again, I'll just see what's out there.
Thank you. We really appreciate that. That'd be amazing.
So then, I guess, and this is just my mind going. We've had a few people that were pregnant when they had their surgery done.
Yeah.
So obviously that is something that we need to be aware of as well, and making sure that those tests are being done before surgery.
Absolutely. And so when you say that, my brain starts ticking over and I go, yes, well, they were probably put on some sort of very low energy diet, which caused, initial weight loss, mainly for the reduction of the size of the liver to make the surgery less risky. But we know just how potent any sort of weight loss can be to increase fertility. And as I said before, it can take the patient by surprise if they fall pregnant and they may have had irregular periods before. They don't realise how quickly their fertility can increase, and it can increase before their periods regulate as well.
Yes. Yep.
Yeah.
So that it shows the importance, doesn't it? Yeah,
it does.
And
even once we start that diet, like once we start that pre-op diet, beware.
Yeah,
absolutely.
I mean, even for people that sort of may not have had a regular period, like you said, but if they're not planning on having any more children, then maybe hubby needs to play his part and
just be very, very aware.
Get a vasectomy or something, and so that we're not taken by surprise.
Absolutely. And yes, again, I feel that this contraception conversation needs to be had by the surgeon. It needs to be a proactive decision going into the preoperative phase.
Yeah.
Yeah, I agree.
Amazing. This has been such a good chat. I really enjoyed it.
Yeah, me too.
So,
thank you.
Thank you so much for joining us.
It's my pleasure. Anytime.
And
we will pop any resources that Dr. Terri-Lynne provides us into the description of the podcast, so you'll be able to access them there.
I'll try and make them patient-friendly, Tash. I'm a science nerd, and I can just go down a rabbit hole and use my big words.
I love that too. I love that too. So
maybe we'd be able to down the track do an online forum, and you can explain some of the
explain some of all of these things
in a live setting.
Yeah,
that would be fun.
It would.